Good afternoon. My name is Dr. Rana Higgins. I'm one of the general surgeons here at the Medical College of Wisconsin. Today I'm joined by Dr. Tina Yen, who's going to be talking with us about parathyroid disease. Dr. Yen started her medical school training at Harvard in Massachusetts. She then went to the opposite side of the country in Washington to do her general surgery residency training, and subsequently then went down south to Houston for her surgical oncology fellowship at MD Anderson Cancer Center. She has then been with us at MCW for the past 13 years, where she is now a professor of surgery and the service chief of breast and endocrine surgery. So welcome, Dr. Yen.
Thank you.
So we know a lot about parathyroid disease. We've heard about it, but just explain a little bit about what exactly is parathyroid disease and what is this primary hyperparathyroidism that people talk about?
Sure. So primary hyperparathyroidism is the most common cause of hypercalcemia, which is elevated calcium levels in your bloodstream. And so primary hyperparathyroidism relates to the parathyroid glands. Typically, most folks have 4 parathyroid glands, which live in the neck near the thyroid gland, and they secrete a hormone called PTH, or parathyroid hormone, which helps regulate your calcium levels in your bloodstream. So normally, if your calcium level is high, the parathyroid glands will decrease the amount of PTH that the body is making and then bring down the calcium level. In folks with primary hyperparathyroidism, typically one or several of the parathyroid glands are overactive, so they're making too much PTH, and so therefore that leads to patients having chronically elevated calcium levels in the bloodstream.
And what are some of the causes of this? How do people get primary hyperparathyroidism?
We don't know. For most folks, it's what we call a sporadic situation where we don't know why people get, why the parathyroid glands decide to become overactive. In probably less than 5% of cases, it's due to a genetic component, so gene mutations that predispose folks to have their parathyroid glands become overactive. And in those situations, typically more than one parathyroid gland is affected.
And what kind of symptoms would people have that maybe might make them suspect, or their primary care physician suspect that they have primary hyperparathyroidism?
So most folks actually are what we call asymptomatic, don't have symptoms. And if you do have symptoms, they're related to your calcium levels per se. So people can have non-specific symptoms such as fatigue, memory changes, concentration problems, issues with sleep. So those are fairly non-specific, and then more specific would be things like bony fractures with minimal trauma, or developing kidney stones. Those are the things that we truly would raise our mind to think, well, are they hypercalcemic, and then could they have primary hyperparathyroidism? Folks can also have digestive symptoms such as nausea, vomiting, indigestion, heartburn. They can have ulcer disease or pancreatitis. Those are kind of the most common things, but again, there's nothing really specific to say I have primary hyperparathyroidism. It's typically someone gets their labs checked, they have a high calcium level, and then that prompts a workup to see if it's due to primary hyperparathyroidism.
So if they are worked up and they find that they have primary hyperparathyroidism, what are their treatment options? Obviously you're a surgeon, but are there medical options, and if so, how does one decide when to pursue a medical option versus a surgical option?
So the only way to fix primary hyperparathyroidism is with surgery. So it's the only way to cure the problem. In folks who are not interested in surgery, or who may not be good candidates for surgery, there are ways to manage the sequelae or potential complications of primary hyperparathyroidism. So people can, let's say a person has primary hyperparathyroidism and significant bone loss. So they can take medications to help their bone health, but not, again, address the problem of the overactive parathyroids. For folks who have primary hyperparathyroidism and aren't good candidates for surgery, or just don't want surgery and their disease is relatively significant, they can go on medications called Cinacalcet or Sensipar, which then lowers your PTH levels and therefore then lowers your calcium levels. So it's almost like a medical way to manage it. But folks don't tolerate that medication well often, so sometimes it's not a great long-term option.
So why come to MCW? What advantages are there to coming to a specialist in parathyroid disease, such as yourself?
Yeah, so even though primary hyperparathyroidism is the most common cause of hypercalcemia, it's really not that common. Like 1 in 1,000 people or so may have primary hyperparathyroidism. And so folks, once they are diagnosed with primary hyperparathyroidism and are considering surgery, again, not many folks do parathyroid surgery a whole lot. So it's nice to come to a place where at MCW we have specific surgeons who are trained in endocrine surgery or surgical oncology who do a lot of parathyroid and other endocrine surgeries. And so with that higher volume, we see better outcomes, better cure rates, so making sure people are truly taking out all of the overactive parathyroid glands, getting a normal calcium level after surgery. And we have, most importantly, we have the ability to do what's called intraoperative PTH monitoring, where we check the blood levels of the parathyroid hormone during surgery. And so if we take out all of the overactive parathyroid glands, the parathyroid hormone level should fall and meet a certain criteria, and that tells us we should have done our job and cured the patient because we've taken out all of those overactive glands. Particularly for folks who may have more than one overactive gland, certainly a situation where it's nice to be operated on by someone who knows what they're looking for, can find everything, knows where to look, what to do, to call for help. You know, there's always at least one of our colleagues around if we are in that situation where we can't find that missing gland or glands. And so it's always good to do that. And then we have good imaging too, which we didn't really talk about. So most folks with primary hyperparathyroidism have disease due to one overactive gland. And so if that's the situation, we can usually identify that on preoperative radiology tests, like an ultrasound or a CT scan of the neck, or a sestamib scan, which is where you get injected with some radioactive material. And then if you have quote-unquote localized disease, then again our goal is that we can go in, do a very small minimal operation, find that one gland, take it out, see the blood levels fall, and then be done in like a half hour, 45 minutes.
And then final question, if somebody did have parathyroid surgery, are there any long-term issues that they might have, or any issues related to not having their parathyroids anymore?
So I don't know if I mentioned this, so we all have at least 4 parathyroid glands in our neck. And so as long as we have at least half of a good one in one's neck, then ideally one should be able to make enough parathyroid hormone so one can maintain a normal calcium level. In some situations where if that's not the case, we don't leave enough functioning parathyroids in the neck, then people will have the opposite problem. They'll have issues with low calcium levels, which is a nuisance, but we can supplement that with calcium and other medications that can help boost the calcium level to a near normal range.
So as long as the diseased glands are removed, then there's typically not many long-term issues.
Correct.
Yeah.
Correct.
Great. Well, thank you so much, Dr. Tina Yen, for joining us today talking about parathyroid disease. Thank you for joining us, and please stay tuned next week for our video session here at the Department of Surgery, Medical College of Wisconsin.